Okay, Chair, we are live on YouTube and you may call the meeting to order.
Yes, it's 9 o'clock. Thank you, Melinda. We'll call the meeting to order. And we need a roll call first.
Absolutely. All right, roll call of the voting commissioners. Commissioner McAllister.
Good morning, present.
Good morning, thank you. Chair Khan.
Present.
Thank you. Commissioner Roe-Dugan. Commissioner Grady.
Good morning, present.
Thank you. Commissioner Van Houweling.
Good morning, everyone.
Good morning, thank you. Commissioner Bond. Commissioner Tyler Garner.
Good morning, present.
Good morning, thank you.
Great to see you.
You too. Commissioner Winkler.
Good morning, present.
Good morning, thank you. Vice Chair Rubelid.
Present.
Thank you. Commissioner Ralston.
I think she apologized. She sent her regrets. You won't be able to make it.
Thank you, Chair. Commissioner DeCerbo.
Morning, all. Present.
Good morning, thank you. And Commissioner Khan.
Okay, do we have a quorum?
We do have a quorum. I just really quickly want to do roll call of the ex officio members as well.
Okay.
Director Richard Whitley.
Here.
Thank you. Insurance Commissioner Barbara Richardson.
Morning.
Good morning, thank you. Ryan High.
Present.
Thank you. And Laura Rich.
I'm here.
Thank you. Chair, you do have quorum.
Okay, thank you. So next item, I'd like to welcome two of the new commissioners appointed, Dr. Mark DeCerbo and Ms. Flo Khan. Are they here?
Commissioner DeCerbo is here, Chair Khan. Commissioner DeCerbo, would you like to make any welcome remarks?
Hey, everybody. Nice to meet you. As mentioned, my name is Mark DeCerbo. Definitely happy to be joining the group. Just briefly about myself, I am the pharmacist member, not representing any chain of pharmacies. Myself, I've been a resident of the state for a little bit over 20 years now. I'm faculty at the College of Pharmacy at Roseman University, as well as adjunct faculty at Touro University. And I'm a practicing pharmacist at Mountain View Hospital, as well as UMC here in Las Vegas. On the state level, I chair currently the Nevada Silver State Script Board, formerly known as the Nevada Medicaid P&T Committee. So again, looking forward to working with all of you. Nice to meet you.
Thank you, Dr. DeCerbo. Next item on the agenda for action, approval of August 17, 2022 minutes. I presume everybody has read the minutes? Motion to approve.
Chair Khan, this is Commissioner Van Houweling. I make a motion to approve the minutes.
Is there a second?
Commissioner McAllister, I second.
Thank you. Any opposed? If not, the motion carries. The next item is public comment. Is there anybody here for public comment? Or just so that everybody is aware, we received written comments ahead of time, and they will be made a part of the record and will be placed on the website for people to review them. Any in-person public comment other than the written ones?
This is as a reminder, if you're joining via the Zoom platform, please use the raise hand feature. If you're joining via telephone, please press *9 to raise your hand. And Chair, I do see that we do have a hand raised from Mr. Patrick Kelly for public comment.
Okay, please be reminded there are 3 minutes for public comments. I'd appreciate if you confine yourself to that time.
Good morning. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. Today, I'd like to address agenda items 7 and 8. Under agenda item 7, the commission will discuss accountability mechanisms in 3 states. It's important to put this conversation in context. Nevada is likely very different from these other states. Our differences must be factored into your analysis. For example, Massachusetts has a robust healthcare delivery system. Nevada has access problems. Massachusetts ranks among the top 5 states in the country for the number of physicians per capita. Nevada ranks among the bottom 5 states in the country. Massachusetts has 33% more active RN license per capita than Nevada. Access to care in Nevada is poor. 67% of the state's population live in primary medical care health professional shortage areas. 71% of the state's population lives in dental health shortage areas, and 94% of the state's population lives in a mental health professional shortage area. Nevada has unique needs that are unlike Massachusetts. This leads me to item number 8. Caps may sound great, but in some areas of healthcare, Nevada needs to spend more to improve access. Cheap isn't any good if you can't access services. The commission needs to take a hard look at Nevadans' needs and develop a rational plan to meet those needs. The PPC must also assure a reasonable rate of return for healthcare providers. If this isn't done, capital expenditures will decrease, facilities will deteriorate, equipment will not be replaced and upgraded, and services will dwindle. In 10 years, Nevadans could have a dilapidated healthcare system because of inadequate reinvestment. The cost to catch up will be astounding. The United States Supreme Court has stated on several occasions that a regulatory framework cannot be so unjust as to be confiscatory. If the rates established by the state do not afford sufficient compensation, they might violate the 5th and 14th Amendments to the Constitution. Please be prudent in your actions. The health of millions of Nevadans depend on it. Thank you.
Thank you. Appreciate it. Anybody else for public comment?
Anyone else, please raise your hand or press *9 for public comment. Not seeing any additional public comment, Chair.
Okay, thank you. So we move on to the next agenda item for possible action, review, discussion, and decision of PPC letter of support for subject 1, topic 1, and subject 2, topic 6. Melinda, you want to take on from that?
Yes, thank you, Chair. So I have drafted 2 letters. One letter is a letter of support for subject 1, topic 1, otherwise known as the Nevada Coverage Study for the Uninsured Immigrant Population. And this item has actually now been picked up and included in a related American Rescue Plan Act, or ARPA, request within the Division of Healthcare Financing and Policy, with the to be put forward for approval of the Interim Finance Committee, or IFC, during their October 20th meeting. So given this new development of the subject 1, topic 1, now on the October IFC agenda, it might be beneficial to include all current IFC members on the drafted list of addressees if the commission wishes to do so, of course. That second letter is a letter of recommendation regarding subject 2, topic 6, which is otherwise known as the Prescription Drug Affordability Review Board, to be put forward during the 2023 legislative session. I've asked for feedback from the commission on both letters over the past couple of weeks, and both are also included in today's meeting materials. I would now like to open this item for discussion from the commission, and please feel free to raise your hand to start the discussion. And I see Commissioner McAllister, please go ahead.
Thank you. Yes, so I do support sending the letter to all the members of the Interim Finance Committee ahead of the October meeting. That's a great suggestion, Melinda. Thank you.
So, thank you, appreciate it. So the commissioners have had access to this before. Is anybody opposed to sending these letters of support?
I do see Commissioner Khan has your hand raised. Please go ahead, Commissioner.
Oh, thank you, Melinda and Chair. First, with respect to item number 1, I have no issues, so that's fine. With respect to the Prescription Drug Affordability Board, I do want, first of all, I want to be clear for the record that I'm speaking on behalf as the commissioner, not on behalf of any company that I work for. So for pharma, they have submitted their own stuff. So, but I am opposed to the letter of support for the commissioner. I know it was done or it was voted on in support when I was not a commissioner, but I do have concerns about what a Prescription Drug Affordability Board would do potentially. So I guess a lot of it is going to be obviously what is contained within the proposal. But with that, I just want to state that the letter really fails to address how patients would be impacted by a PDAB. Like, there's no requirements in this proposal or in this letter that suggests that patients are actually going to benefit from any of the proposal that you put forward or any of the limitations on the cost of the prescription drugs. So there definitely is a shortfall there. I would suggest, as part of any PDAP proposal and prior to its implementation, that there be some guarantee that the patient must experience a reduction in out-of-pocket costs on needed prescription drugs if you're going to do that. And it should not be assumed that just because you put a price cap on the prescription drug, that the patient will reap any kind of benefit. But on that note, I might add that I don't believe any proposal should include a price cap or price control, because we know, based on history and experience, that a price cap will severely reduce patients' access to medicine, as seen in many other countries. We've seen this before. So I think that has to be taken into consideration as well. In addition, the letter fails to address that drug pricing is not just one group. Drug pricing occurs by any number of players within the system. So, for example, this only addresses the pharmaceutical drug manufacturers. It doesn't look at actions of the PBMs, pharmacists, wholesalers, insurers, who all have a role to play in drug pricing. So without incorporating them into any kind of PDAB, there are no guarantees that patients are actually going to receive the benefit. So because of this, I regret that I must oppose the letter.
Thank you very much, Commissioner Khan. Appreciate that. So this was discussed and deliberated upon last time. Is there anybody else opposed before we move on to the next subject?
Commissioner DeCerbo, I see you have your hand raised.
Yeah, no, I know I'm new to the group, but I echo some of the previous comments there in being opposed, more from the pharmacy side of things. We see a lot of consolidation in the end chain or independent pharmacy users here, and something like this, by not articulating what happens independent of meaningful PBM reform in the state, I feel like this will harm the independent pharmacies in the state, as so many other things have done to this point, leading to consolidation and actually worse access and worse pricing for patients. We've seen it in some other states. Oregon is a good example there of many pharmacies closing due to good-natured but incomplete activities like this. So I think something like this is well-intentioned, but without meaningful PBM reform, any action in that area, I think this could have some very strong unintended consequences and actually harm patients. So I'm opposed in its current form.
Thank you very much, Commissioner. Anybody else opposed before we have to take? If nobody else is opposed, then I would presume majority is in support. If anybody else is opposed, please let us know now. Linda?
Commissioner Winkler, please go ahead.
Hello. So just to clarify, we're just reviewing the letter that we want to send. We've already agreed that we're supporting
Yes.
it. I'm not opposed to including language that specifies that the primary purpose of doing this is to increase affordability for patients. However, this is just a letter of support. It's not a policy document or an actual proposal. So it's really kind of out of our hands after we've sent this as something we want them to look into. Thanks.
Thank you. Anybody else? Melinda, do you see anybody wanting to speak?
Chair, I'm not seeing any additional hands raised.
Okay, so I think as it was just mentioned, this was deliberated upon and acted upon last time. And we have 3 people right now who are opposed. So the rest, I am presuming, as I said earlier, are not speaking against it. So this would carry as presented for proceed with the vote. Thank you. The next item, Melinda.
Yes, Chair. And just to clarify, I am to send the letter for the immigrant health insurance population study to all members of the IFC, as well as the legislatures that were listed under that item.
Excuse me, Chair Khan and Melinda, this is Commissioner Van Houweling. Can I just ask a technical question or a procedural question? And just refreshing, and since we have a few new members, and back to Commissioner Winkler's question, is this an actionable item? Or obviously sending the letters is, but do we need to take a vote on this letter to be sent out, just from a procedural standpoint?
To my understanding, we don't need a formal vote. We just obviously indirectly it is by majority wanting to proceed with sending the letter. The only discussion today was whether there were any changes or objections that needed to be added or subtracted based on the fact that we had deliberated already last time.
Okay, thank you, Chair Khan.
Thank you, Mayor. Okay, proceed, please, Melinda.
Thank you, Chair. With regard to this next item, I would now like to do a brief overview of the healthcare cost growth benchmark in Nevada and what's been accomplished so far, what we're in the middle of completing, and where we anticipate heading with this project. So after being accepted into the Peterson-Milbank Program for Sustainable Healthcare Costs in early 2021, our PPC began the process of being appropriately informed about implementing a healthcare cost growth benchmark in our state. Executive Order 2021-29, late in December, then established the Nevada Healthcare Cost Growth Benchmark as a first step toward making healthcare spending more transparent and healthcare coverage more affordable. The executive order set the benchmark for how much per capita, or the average cost per person, healthcare spending should grow in a year. The executive order also charges healthcare payers and providers to work together to strive to meet the benchmark. As of April 2022, the Department of Health and Human Services, Office of Analytics, and the Public Employees Benefits Program, or PEB, each completed and released a 5-year phase 1 cost driver analysis report for Nevada Medicaid and PEB, whose data was used as proxy for the commercial market. The Office of Analytics and PEB are currently working on phase 2 reports to drill down into service category spend, focusing primarily on price and utilization for specified categories of services. In May of 2022, the state requested all Nevada insurers to respond to a baseline data request for commercial, Medicaid, and Medicare. Just last month, the PPC voted to advance a bill draft request to the Legislative Council Bureau to codify the cost growth benchmark executive order into statute during the 2023 legislative session. And then in fall of this year, the Office of Analytics and PEB are looking to complete their analysis of the phase 2 cost drivers, or the drill downs into why the cost is showing high in these areas, and to really tell the story. And this will focus on, price and utilization. As you can see, this data and findings are planned to be presented to the Commission in December. Additionally, we've asked our neighbors in Oregon to be a guest presenter for the Commission in October to gain some insight into some of their lessons learned with benchmark accountability mechanisms. Oh my gosh, I'm about to be signed up in 10 minutes. I have time. And lastly, this fall, the Commission will be asked to consider 1 to 2 cost growth mitigation strategies to focus activities on in calendar year 2023. These strategies will be informed by the phase 1 analyses and help individual entities and the state strive to meet the benchmark. January through March of 2023 will be reserved to validate, analyze, and review baseline benchmark findings with Nevada insurers who responded to the state's request for the aggregated baseline benchmark data. Then in April of 2023, we plan to present the first baseline healthcare cost growth benchmark findings to the PPC stakeholders and the public. So I just wanted to pause there really quickly if there were any questions before we move on to the next portion of this agenda item. And seeing none, we'll go forward. Now, I'd like to transition to highlighting some key findings of the Nevada Consumer Healthcare Experience State Survey, or CHESS. So as a background, Alterum's Consumer Healthcare Experience State Survey is designed to provide reliable state-level estimates that convey respondents' unbiased views on a wide range of health system issues, including confidence using the health system, financial burden, and fixes that might be needed. Nationally, consumer worry about healthcare affordability is well documented, with similar Alterum studies or surveys already completed in over 24 states nationwide. However, results of the Nevada CHESS offer unique insight on the specific concerns in our state. This survey uses a web panel from Dynata with a demographically balanced sample of approximately 1,000 adults ages 18 and older who live in a given state. Currently, the survey is conducted only in English and Spanish. The state asked Alterum to include respondents who are truly statewide in Nevada, meaning our urban, rural, and frontier areas, as well as north, south, east, and west, as it's very important to gauge public opinion encompassing the demographic and geographic diversity of our state. Alterum fielded the survey in Nevada earlier this summer, from June 21st through July 8th, and has now analyzed and produced data briefs detailing the survey results. We do plan to upload the data briefs to our PPC website once they're available to publish here very shortly. As you can see, the state asked for the survey briefs on 3 important topics: healthcare affordability in general, prescription drug cost concerns, and hospital prices. And really quickly, I do see Commissioner Khan, you have your hand raised. Did you have a comment?
I don't have a comment. I just have a question. Are we going to be able to see the survey?
Yes.
Thank you.
Yes, absolutely. I'm going to send that to all the commissioners, and then I will post on the PPC website. All right. So moving into some specific highlights from the 3 comprehensive data briefs. A substantial portion of Nevada respondents worry about affording healthcare costs, both now and in the future, and many, or 65%, reported experiencing financial hardship due to hospital costs. Most Nevada respondents believe the major reason for high healthcare costs is unfair prices charged by powerful industry stakeholders such as hospitals, pharmaceutical industry, and health insurers. When asked about the top 3 healthcare priorities that the government should work on, Nevada residents most strongly supported addressing high healthcare costs, including prescription drugs, and perhaps the most astounding, that over half, or 59%, of all respondents reported delaying or going without healthcare during the prior 12 months due to cost. And then I also wanted to note here that healthcare cost was not necessarily defined in the survey, so it was up to the interpretation of the respondent. Additionally, some data points describing the government policy solutions that Nevada respondents were most highly in favor are depicted on this next slide. Yeah, thank you. As you can see in the 3rd line down, a majority, or 81%, of Nevada respondents are in favor of government policy solutions as described in the Healthcare Cost Growth Benchmark PPC BDR that's submitted for 2023. As I had mentioned previously, we will be posting all 3 briefs in their entirety on the PPC website later, hopefully this next week, in addition to including them with the meeting materials posted online for today's meeting. And with that, are there any questions or comments before we move into the next agenda item?
Melinda, I have a quick question on that.
Absolutely.
With respect, particularly with setting limits on healthcare cost growth, do you know, were there questions around trade-offs that would have to be made in order to achieve that? So for example, were the recipients or the survey respondents asked if, you know, they had to make a choice between setting higher or limiting prices, but also knowing that that could mean that they would have more limited access to medicine? Were they given those kinds of choices in the survey?
I do not believe so, Commissioner. I will verify that for you, but I don't believe it went into that great of a detail.
Okay,
Yes.
thank you.
Second, could you please identify yourself for the record? Those who are speaking, kindly identify yourself for the record.
Sure, Chairman. This was Flo Khan.
Okay,
Commissioner Flo Khan. Thank you.
Thank you.
okay. Go ahead, Melinda. What else do you have?
Oh, I was just going to ask if there were any further comments before we move on to the next agenda item. Commissioner Tyler Garner, please go ahead.
It's just a quick, just wanted to solicit your thoughts. Based on the findings of the survey, are there particular areas that have implication for our work? So we just had the discussion about the letter. And one of the themes there is this notion of capping costs. Are there other implications that were noted in the survey?
There are, yes. This is just a very brief, high-level highlight of the survey briefs. The data briefs themselves are very comprehensive and do go into more detail. And I'm really excited to share those with you when they're available.
Thank you.
Thank you.
I have a quick comment. So in capping costs, this is a Pandora's box. It's multifactorial, and we didn't ask specifically what areas people not going for care because it's expensive. I think that's a very vague question that was asked because there are multiple factors. The insurance component is one of them, the drug component is one of them, and the providers is one of them. The providers, by and large, go by their contracts with the managed care companies up front. So irrespective of whatever their cost or charges would be, the hospitals, the doctors would accept whatever the negotiated rate was. So one has to keep that in mind when we are talking about containing costs. Where is the cost factor most impacted? Plus, by capping the costs, we already have a challenge in the state where a lot of providers, at least the doctors that I know of, do not take Medicaid because of the cost is not adequate from their point of view to take Medicaid patients. So these things have unintended consequences. So one has to be careful when we are trying to say cost factors, control, and caps. It affects the access once we go into that area of capping things.
Melinda's computer is unfortunately rebooting at the wrong time. So in her stead, Tyler, I want to recognize you, and then you, Mark.
Hello, this is Commissioner Winkler. So I was wondering if these, beyond us receiving the briefs, which thank you, Director, very happy to receive those, will these be presented in any way? I assume this is going to be put together in a slide or something for maybe one of our standing committees or something. And would there be a way for us to get a similar presentation at a later date? Thank you.
Yeah, so I know that as she indicated a few minutes ago, Melinda intends to give you the full briefs once they're completed. I'm sure it would be possible to ask the researchers at Alterum who actually did the work to have them come and present to you as they have informally to Melinda. And you could ask them all manner of questions. They are incredibly comprehensive surveys. I was really impressed with it. I had nothing to do with it, but really impressed with the work. And I will note, I think that this last bullet on slide 10, 59% of respondents are delaying or not going with care because of cost is, I think the most compelling data point here, and really urges, this body to consider what action it can take.
Any other comments from anybody else before we move to the next item?
Yeah, there are two hands up, Chair Khan. Mark?
Okay.
Yeah, I just wanted to echo some of Chair Khan's comments.
Please identify yourself.
Hey, this is Commissioner DeSerbo. And I just wanted to echo some of Chair Khan's previous comments on some of the unintended consequences of the spending caps, the spending limits. in so much as are often bound by contracts. And I think of what we do on the Silver State Script Board, working with Optum and now working with Magellan in our fee-for-service Medicaid population. We don't always go with the least expensive option. A lot of times the better drugs do cost a little bit more. And by not being artificially constrained, we can offer fee-for-service population the better, if not the best drugs out there. And we might be hamstrung if we were forced to work within, say, an artificial price cap. So in some ways, the price caps have unintended consequences and actually can limit access to the best medication. So I would just echo those comments there on the spending limits previously in terms of what we see in our Medicaid fee-for-service population.
Thank you.
I just want to note, I think Melinda was pointing to that third row, not as a price cap, but as representing the cost growth benchmark that you all have adopted, which is not a price cap. I mean, we'll talk about price caps later, but this third row is not about a price cap. It's about setting, in this case, a voluntary target to aim to achieve to slow the rate of healthcare spending growth.
So if I may, actually, you have the subject of price caps in the next agenda item.
Correct.
So there's questions on price caps. Let's hold it for that agenda item. Any other questions on this agenda item?
Leanne?
Commissioner McAllister, for the record, I put in the chat and I'd like to made part of the record and share it out with the other commissioners, the Congressional Budget Office estimate of the impact of pricing costs on the development of new drugs, because they actually found it to be quite moderate and wouldn't be much of a problem. And I think it's important that the commissioners review that report.
Thank you. Anybody else on this subject before we go to the next agenda item?
That's it, Chair Khan.
Thank you very much. So we'll move to the next agenda item. Number 7 is cost growth, benchmark accountability, mechanisms in 3 states, findings from a study of Massachusetts, and potential accountability mechanisms for Nevada. So my own caveat to this before we open the discussion is I've believed this for 45 years I've been here. Nevada is different. What works in another state doesn't automatically work in Nevada. The dynamics are different. The population mix is different. The whole process systems are different. So I would take this with a grain of salt. It's good to have information, but to see just because it's working in another state will work here, I would very strongly caution against that interpretation. So go ahead.
Okay, so it looks like Melinda has not rejoined us yet. So for purposes of introduction.
You can start off with the presentation.
Okay, so this is Michael Baylett speaking. At Melinda's request, I'm going to provide you with a look at what other states have done to foster accountability for cost growth benchmark performance. Our current approach in Nevada is to utilize public reporting at the state, market, insurer, and large provider entity levels. Today, we're going to look at 3 states. So this is 3 of the, I guess we're up to now 9 states that have cost growth benchmark programs. I'm going to look at what they have done or what they're planning on doing. I'm going to start with Massachusetts because recently there was a study performed of Massachusetts accountability mechanisms. And so I'm going to start with information from Massachusetts, and then I'm going to share information in less detail from Colorado and Oregon. So as you might recall, Massachusetts was the first state to adopt a cost growth benchmark. It did so via 2012 legislation. That legislation also established a body called the Health Policy Commission, which was authorized to monitor compliance with the benchmark and to establish some accountability mechanisms. So Mathematica, with funding from the Peterson Center on Healthcare, which is the same entity that's funding support for the Peterson Milbank program, performed a qualitative analysis to look at how Massachusetts benchmark and the Health Policy Commission's accountability mechanisms had influenced motivation and actions by a number of players. And they did this to help draw out lessons and considerations for other states as they consider potentially using accountability tools. So exactly for the purpose that I'm sharing it today. They gathered the information through interviews with payers, providers, state agencies, other interested parties. They conducted about 50 interviews between last November and this past March. Okay, and the information that we're sharing, I don't think it's formally been published yet. I think we got all the Peterson Milbank states got a presentation on it, but it will be published and will be shareable with you when it's out. So first, they gathered, before asking about accountability, they just asked what do people think about the benchmark. And in all their questions, they collected both strengths and weaknesses. So the strengths were that everyone broadly felt that having a benchmark created a focal point for conversation among state leaders about healthcare spending. And at least during the initial years, and now, they're on a decade of having had one, they felt that the benchmark influenced contract negotiations. And I will say from interviews that I've done myself with Massachusetts insurers, that and providers, they certainly have used their benchmark for negotiation. I also recently heard from a physician executive who co-chairs the PPC equivalent in Rhode Island that he told me payers routinely invoke their benchmark at the negotiation table. So that was something that happened in Massachusetts and considered to be a strength. The weaknesses is that not all providers agreed that the benchmark influenced their business decisions. And I will say it also appears that there was some waning influence over time. So what worked in the initial 5-6 years wasn't as influential in later years. There were also stakeholders who said that the benchmark, while focusing on cost growth, doesn't address variation in levels of spending. So there are some states, and Massachusetts is one of them, where there's huge disparity in spending that largely correlates with market power. So the dominant health systems in the state have prices that are far above those that are not. And the cost growth benchmark has not addressed that issue. So it's addressed the rate of growth overall, but not the disparity in payment levels. All right, so this is not about accountability. This is just perspectives on their benchmark. I'm now going to talk about 3 different accountability tools that are in the statute in Massachusetts. The first is to have public hearings. These aren't just open community meetings or public meetings. These are technically hearings where people are called to come testify in front of their commission. 2, they issue a formal report each year that not only has the results of benchmark performance, but it also contains extensive quantitative analysis of what's driving spending growth and has policy recommendations. And 3rd, they have something called performance improvement plans, which I'm going to talk about a little bit later. So first, there are public hearings. They hold these annually. They can be 2 or 3 days in duration. The reported strengths are that they help to make healthcare costs and spending transparent and serve to shine a light on what payers and providers are doing to address the key cost drivers. It was observed that the entities take the hearing seriously, and they put a lot of time into their presentations. They are live broadcast on YouTube, I think. There are a lot of people who attend them in person and watch virtually. The weakness is that attention, including media coverage, which was very high in the initial years, has waned over time. Some thought that the witnesses have been able to evade tough questions or haven't been asked tough questions. And there's a general sense that the hearings, while they were influential in the early years, have been a little less so, and they don't seem to have influence on entities' behavior after the hearing's over. The second accountability tool are the reports that are published each year. The policy commission staff put tons of time into them. They were commended for making complex information understood. They're commended for focusing on solutions and major cost drivers. And some policymakers said that they use them to inform their policy decisions. Those who saw weaknesses pointed to few of the policy recommendations actually having been adopted. And also the reports have a lag of 2 years, which is what happens when you use claim data, right? You're going to always going to have a lag. Okay, I would say the most significant limitation is the first one, that while the Health Policy Commission has recommended many well-researched and supported recommendations, that relatively few of them have been adopted. And frankly, that has more to do with lack of legislative action than anything else. All right, and so then last they have something they call performance improvement plans. So the performance improvement plans are defined in statute as something that the Health Policy Commission may require if the rate of spending is considered excessive, meaning it's above the cost growth benchmark, and although the statute doesn't say this in quite these terms, there's no justifiable reason for it. So the Health Policy Commission for years has had confidential meetings with organizations and had conversations with them, but that's separate from requiring an actual performance improvement plan. Belinda, it looks like you're back.
I am. Thanks, Michael. I just noticed there was a question in the chat from Commissioner Tyler Garner. Just wondering, were there suggestions for mitigating the waning effect? And then for the providers noting that their business practice did not shift, did they indicate why or provide any context for that? I don't know the answer because I didn't collect the interview information, but I can opine on this because it's a state that I know pretty well. So Melinda, can you read the two of them to me so I can answer them in sequence? Sure. Were there suggestions for mitigating the waning effect?
Yes. So the Health Policy Commission has just this year sought additional authorization and authority for taking action because they too feel that after 10 years, the tools that worked early on are not working as well anymore. And so they are seeking additional authority from the legislature, which is what created them and gives them their current authority. And the second question was?
Sure. So also for the providers noting that their business practice did not shift, did they indicate why or provide any context that you know of?
Yeah, so I don't know the answer, but I will share that you might recall months ago, I shared data on healthcare spending patterns in Massachusetts. And Massachusetts for the first several years came in on average at their cost growth benchmark. So while the providers might say that, the benchmark was being hit just about every year. And Massachusetts commercial spending growth on a per capita basis, which was running higher than the US average every single year until they have their benchmark, has been under the US average every year since 2013. So while some providers might say that, and I don't doubt that the benchmark has had more impact on some providers than others, I would say that the data indicate that it certainly has had impact. I suspect that it has had less impact on the organizations with the greatest market power. And in fact, coming back to this performance improvement plan, the first performance improvement plan requirement was applied just this year, and it was applied to the largest health system in the state with the most market power. So probably not a coincidence.
I have a question. This is Commissioner Khan. With respect to quality of care, has there also been simultaneous surveying or work done to say quality of care and how that's impacted health outcomes?
Yeah, so the analyses of which I'm aware of quality and equity, actually both, do not show any decline in quality. Healthcare quality in Massachusetts is pretty high. And they're, at least for the measures that are applied. And I want to note that there are limitations to the measures that are used in terms of their number, but at least those that have been applied do not show any harmful impact on quality or equity.
So this is Dr. Khan calling about, in your presentation, you said annual rate spending growth considered excessive may require to develop and implement performance improvement plan. Performance improvement plan, are you talking about financial performance improvement where the finances should go down? Performance improvement language is used for quality improvement. It used to be quality assurance, quality improvement, and now performance improvement. It's the clinical performance. That's what it implies as far as I understand. And then I have a problem if you're going to have regulation required to develop and implement this program as a penalty if they don't do this, this, and this. So now you have to do this, whatever that performance improvement plans mean. And yes, the Commissioner Khan has implied the quality. Yes, that's the first thing that goes down. Nobody has established good, objective quality measures nationally. We all talk about quality, but what is that quality? We created some benchmarks nationally, and those are just benchmarks, very vague, and we start judging the institutions and providers based on those created benchmarks. Then the second point is, as you start controlling and regulating providers, access goes down. One has to, I feel very strongly about the effect on access. One may say it didn't affect access in Massachusetts. I understand that, and that's not Nevada. So Nevada is already affecting access. We have already talked about it. There's significant problems with access already. So anyway, I have said my piece, and let's proceed if there's somebody else wanting to say anything.
Well, Chairman Khan, this is Commissioner Conigan. Just one thing I just want to point out too. The reason why I asked the question about quality is it's really easy to look at these in silos. So you can talk about bringing down the cost of prescription drugs and holding it down the line, but it could have the impact by them not having access to the most appropriate medications that they could actually end up costing more over in the hospital space. So that's why I was questioning, like, have we seen health outcomes across the board to kind of judge, are we, in doing one thing and controlling costs over here, are we actually exacerbating the problem over here? And so that's why I was asking, like, how does this work? The same applies, Commissioner Khan, to your point about providers, right? You can hold down the cost of providers, but if it means that people aren't going to be able to access them, then we haven't really solved the problem. So that's why it's kind of got to be looked at holistically, not siloed.
And I agree with you fully on that. And I think if Commissioner Van Holling is on, he can chime in. This affects the hospital services. Hospitals invest on new technology, very expensive. You do not recover even the cost basis of that for a few years before you can. If we are going to start controlling the costs, hospitals will not be able to get new technology because they'll start losing more money because the reimbursement for the new technology. And one thing that comes to mind is the ECMO. Without going into technical details, it's a very sophisticated, relatively speaking, new technology. Very, very expensive. Large number of employees are involved with one patient, et cetera, et cetera. And the hospitals, correct me if I'm wrong, Commissioner Van Holling, do not necessarily recuperate everything for a few years, if at all.
Chair Khan, this is Commissioner Van Holling. I'll defer to Commissioner Winkler first because he had his hand raised, and then I do have some comments as well.
Okay.
Thank you.
Thank you very much, Commissioner Van Hollen. This is Commissioner Winkler. I just wanted to say that there's a lot to these slides coming up, and really my understanding of this is just presenting what Massachusetts has and what stakeholder perspectives on those are. And at the end, we'll have an opportunity to talk about the applicability of the things that we're learning about. So I would appreciate being able to just to get through these next few slides and then being able to discuss these options. The commissioners would agree. Thank you.
And we'll take Commissioner Van Holling's comment and then we'll proceed with the presentation.
No, in light of Commissioner Winkler's statement, I agree. Let's hold it to the end, and I will. I think everybody will have an opportunity. So yeah, let's let Michael get through the slides, and I'll say my comments towards the end, if that's okay, Chair Khan.
That's fine.
Yeah, thank you. But I will raise my hand at the appropriate time.
Okay, so let's proceed.
Okay, so The Performance Improvement Plan was part of the 2012 legislation. For a variety of reasons, the Health Policy Commission never applied a requirement for a performance improvement plan until this year. And I think that raised a lot of eyebrows in the state. People who saw this as a strength thought that the performance improvement plan, which is public, gave some insight into what, in this case, providers were going to do to bring down performance. Because, Chair Khan, to answer your question, the performance improvement plan is supposed to be the plan of the organization to slow their healthcare spending growth so that it comes in below their benchmark. And this particular organization had exceeded the benchmark multiple years. And others thought having this plan was going to encourage organizations to keep their spending below the benchmark because they wouldn't be identified publicly as having to submit a performance improvement plan. Limitations identified were several. A number of people pointed to only one performance improvement plan having been required over a decade. That some of the entities that contribute to spending growth are not held responsible because this is only applied at at organizations for which lives are attributed through primary care providers. So if it's an entity like a pharmaceutical manufacturer or independent specialty group or a hospital that doesn't have employed physicians, then they wouldn't be held accountable. The third criticism is that the focus of the plans are on the rate of growth and not on the levels of spending. This gets at the spending disparity issue, which is a hot topic in Massachusetts that I referenced earlier. And then finally, the fine for not complying is low. Okay, so that's what we know about experience with Massachusetts. Again, their accountability tools are really primarily, I would say, two. It's public hearings and the performance improvement plan. So there are a couple of other states that have taken action, but let's first summarize what we've learned from Massachusetts. They appear to have had early success by either applying the tools or the threat of the tools being applied in holding spending below the benchmark. The influence of their accountability mechanisms seems to have waned over time. And most respondents and the Health Policy Commission itself believe that they need greater powers now to ensure the benchmark will continue to be met in future years. Okay. All right, so let's look at a couple other states. So first, California. So California is the newest cost growth benchmark state. They just passed cost growth benchmark legislation in 2022. It is expansive. And they will have the best staffed, largest program, which probably goes with being California, after they get it up and running in 2023. There are a number of accountability mechanisms in the legislation. There is requirement for public reporting of results and annual public meetings, which is not exceptional, but there's progressive enforcement of compliance with the benchmarks. So initially there's provision of technical assistance, and then required testimony at public meetings like Massachusetts, performance improvement plans like Massachusetts, but then assessment of escalating financial penalties, which Massachusetts does not have. And none of this has been implemented because, as I noted, the legislation just passed, but this is what's in it and what they will begin to design for implementation in the coming months. The other state is Oregon. So Oregon's Costco target legislation passed last year. It has accountability mechanisms that have not yet been applied. So what are those? So again, public reporting and annual public hearings, not meetings, but hearings. Also a requirement for a performance improvement plan for any payer or provider organization that unreasonably exceeds the benchmark in a year. So as in Massachusetts, the overseeing state agency, which in this case is the Oregon Health Authority, has the responsibility for assessing whether the exceeding of the benchmark can be justified or not, or is reasonable or not. And they've got to apply criteria for that. Organizations that are late or incomplete in their data submission or their performance improvement plans can be fined. But further, payers or provider organizations that exceed the benchmark in any 3 of 5 years without justification are subject to a financial penalty that will vary based on the amount of the spending that exceeded the benchmark. So in Oregon and California, we have 2 states that have financial penalties for exceeding the benchmark. None of the others do. Massachusetts does not. And I'll note all the other states also don't have this, but these 2 states do. And at our next meeting, we have the woman who manages the Oregon Cost Growth Benchmark program scheduled to make a presentation to talk to you about what they have done for accountability, because they've built out a whole framework with criteria and processes that's been very planful. This all went through their advisory body, so their version of the PPC was involved in helping to shape it. And you'll have the opportunity to ask her questions at our meeting next month and to go into greater detail than I have done today. So this is obviously part 1 of a conversation about accountability. As a reminder, the Cost Growth Benchmark BDR includes public reporting and an annual informational public hearing, which is similar to all these other states that I've shared, but frankly, many other states do something similar. And following next month's presentation from Oregon, you can decide whether you want to consider whether Nevada should pursue other accountability mechanisms beyond the public reporting and public hearing. So I'm going to stop there and invite questions and comments.
Please raise your hands, and Melinda, if you could kindly identify, I would appreciate if there's one question per commissioner so that everybody has a chance to chime in.
Absolutely, Chair. Commissioner Van Houweling, please go ahead.
Okay, good morning, everyone, and thank you, Michael, for the presentation. As I'm sitting through this and been sitting through meetings, and we've got some new commissioners that have joined us, I kind of reflect back to our first couple of meetings where we were identifying what the charter was for this organization and where we were going, and I reflect on access and looking at some of the key areas that why Nevadans were leaving our state to access care across the spectrum, and leaving to other states such as California and Utah and Arizona. So I as I listened to all this, I'm a big believer in small steps and wins quickly. To me, this is really PhD work, and I feel like we're still in the undergraduate level on some of this. And as I listen to a lot of this, it takes a lot of time to materialize. So I just look at the PPC's time and energy on where can we get some quick wins. And I agree. Looking at Chair Khan mentioned, obviously we can learn from other states, but as I learned that when I moved to Nevada in 2008, we like to do things our own way and put our own stamp on it. And we are uniquely different, certainly from Rhode Island and Massachusetts. It's interesting to see other states around us taking this charge, but certainly scale and size makes a difference in regards to Nevada compared to others. And they certainly have a much more robust system, especially in healthcare on the East Coast, because of the nature of graduate programs. And as we heard from Mr. Kelly earlier about the physician per capita, and certainly we have rural challenges that are very complex for us. But I just get a little concerned on, I reflect on years ago trying to help out and getting more people on the Silver State exchanges and trying to bring more private healthcare companies to Nevada. And I just do not want to discourage people from entering our state, creating jobs and providing more access and more insurance. I'm not sure if the commission knows, but we have close to 1 million people on Medicaid when you include adults and children. 902,000 of our Nevadans are in Medicaid. And I would hope that we could really look seriously at tackling some of those problems, because that truly is a poverty indigent program and it continues to grow. So I look back on some of the things that I thought we could tackle early on, creating reciprocity or credentialing speed or privatizing some of the plans. But I think we just always need to think about access, and will this improve access or limit the availability of access in the state if we start ratcheting down on things that I think are going to take years to materialize. So again, I just want to be cautious too that Nevada comes up with its own solutions and that we do learn from others. But again, to me, this is very high level work, Michael, and I appreciate your diligence in educating us. But I would hope we would continue to be cautious in biting off more than we can actually deliver, or may have some consequences down the road on limiting access because of, payers may exit the market. And again, when we look at even at UMC, and we're very similar to every hospital in the state, our amount of commercial business that we're actually talking about that could actually impact based off of programs like this is very limited. As you know, Medicare, those rates are set by the federal government. The state Medicaid rates are worked in conjunction with providers and our physicians and our hospitals and clinics throughout the state. So I do caution that we're spending a lot of time on this, but I'm not sure if we continue to have growth in certain sectors on certain payers, this will be as effective as we think it is. I personally want to reduce that number of individuals that are on Medicaid that are being born into Medicaid systems. I know Mr. Whitley is on the phone, but I know probably 3 out of 4 babies born at UMC in the state are born into Medicaid. And how do we raise the, get people out of the poverty level and being born in ICUs and other things? So again, it's a little long-winded answer, Chair Khan, but I certainly don't want to, we just got to think about the consequences on setting caps and diminishing research, especially in the pharma as well. We certainly want to be innovative, but we also want people to invest in the healthcare systems in the state of Nevada. So we just have to be careful on some of these moves that could have a long-term effect that may be very difficult to unwind. Chair Khan, Melinda.
Are there any
Everybody
other
heard that.
comments? Thank you, Commissioner.
Thank you.
Any other comments? Commissioner Tyler Garner, please go ahead.
Thank you. I just want to say I really appreciate this rich discussion, even the discussion around how we're talking about access and having the benefit of not only hearing from the respondents from the survey, but also your particular positions as folks actually engaged in that industry. And so even as it relates to something like access, we now know that access isn't just like, oh, well, if we set some standards or expectations around costs, will it reduce access? But we already know through the survey respondents that it has reduced access because they're not accessing it due to cost. And so I want to encourage us to push through our fears around crashing the system, maybe to consider some strategies that we can take, recognizing that it'll be incremental, that with anything, there's some costs and some gains that could be made, but with a firm commitment to moving the system forward in ways that allow more folks to access the system and not solely looking at it from a provider standpoint, but because we're the Patient Protection Commission, looking at it and taking into consideration the patient's perspectives about why they are not accessing care. And so appreciate the thoughts, hope it goes into our thinking about strategy and process and the framework for it, and want to encourage us to not get stuck in our fears around some of these things.
Thank you, Commissioner. Are there any other comments? Seeing none, Chair.
Okay.
I can't tell you how much it means to me that you guys.
All right, so we move on to the next.
And then things happen, like of course the Harrison scale at Green.
Next item.
Melinda?
Oh, thank you, Michael. Yeah, so based upon the discussion that we've been having so far, I just wanted to note that these different strategies that we're talking through today should be looked at as kind of a menu of options, different tools that are in the toolbox that the PPC might want to consider as different, policy options or other things rather than a BDR, different opportunities that the commission might have. And they're not necessarily saying that we have to do any or all of these things, and just want to put that out there that, these are different options, and would like you to have an open mind as we go into this discussion, talking about these different strategies that are available to us. So with that, Michael, please feel free to go ahead. Thanks.
Okay, thanks. So my colleague Alyssa and I are going to go over two different categories of price growth mitigation strategies that other states are either pursuing or considering. We're going to introduce other ones at our next meeting. And so this is a sequence of conversations. And as Melinda said, you can decide that you like all of them or you like none of them. But the reason we're presenting them to you is so that you can consider what actions might you want to support to ensure that the cost growth benchmark is met, and perhaps more importantly, that 59% of Nevadans who are not accessing care or delaying it because of cost goes down as a percentage, because that's a profound access problem right now, and it's driven by cost. So I actually covered this a couple of months ago. We didn't have a lot of time to discuss it, and the composition of this body has changed a little bit since then. So I'm going to cover it again, and this time you'll have more opportunity for questions and comments than we had last time. So first,
new commissioners should have had access to your presentation for the last time, unless they haven't had a chance to look at it, because if all the others have had already the opportunity to listen to your presentation or read it, then we may want to, in the interest of everybody's time, just move on to the current one, unless any commissioner has specific questions who are new to the commission and have not had a chance to look at the previous presentations. I am concerned about duplication in the interest of everybody's time.
I see Commissioner McAllister, you have your hand raised.
Yeah, I move that we let Michael give the presentation. I'd like to hear it.
Anybody else?
Commissioner Winkler?
This is Commissioner Winkler. We agreed that we were going to go to this topic and discuss it. So I really would like to be able to do that.
Let's go ahead.
okay, so this first strategy is actually two different strategies: provider price caps and provider price growth caps. And why focus on this? Well, data that we have, national data, and I will also say data that we have specific to the other Peterson-Milbank states, shows that what's driving national healthcare spending, especially in the commercial market, is provider price increases. Okay, it's not increased utilization of services. In fact, for some services, utilization per thousand has been dropping over the last several years. And so that's why we focus on prices, because that's what's generating spending growth, especially for commercial or employer-sponsored insurance. So you can see here, this is data from the Healthcare Cost Institute, which produces analyses using commercial insurer claims. Overall spending increased 9%, but utilization decreased 5.4%. So it was all about prices that went up 16%. Okay, and where did they go up? They went up across all service categories. I will say for some faster than others. And I will also say that having looked at state-specific data, that the rates of growth by service category do vary a little bit from state to state, although there are some service categories that are consistently higher than others if I generalize across states. So again, two different concepts. A provider price growth cap is the first one. So this is a regulatory limit on the percentage by which insurer payments to providers can grow annually. So it's not setting prices, it's not capping prices, it's capping how much insurers can increase payments annually. This can be applied to certain classes of providers where price growth has been problematic, or more broadly. And again, this is an insurance regulation strategy. A price cap is different. This is setting an absolute limit on how high prices can be. So prices can be anything below the cap. Can be applied in multiple ways across the whole insured commercial market for just out-of-network payments, which has been a source of consumer complaint in recent years. It can be applied just within a public employee benefit program or just within a public option. And because there are these different ways, it can be implemented through the state's purchasing authority and or through insurance regulation. So why do it? As I said, prices are the factor driving healthcare spending growth. And so there's no way that spending affordability is going to improve if price growth continues at the high rates that it's been in recent years. High prices increase premiums. They also increase out-of-pocket costs and harm access to care, as we could see in the survey results. This also addresses market dysfunction. We know that in an efficient, well-functioning market, you wouldn't have lots of variation in prices being paid, but that's what exists commonly in every state. And I'll note, in one state that has a price growth cap, Delaware, they actually use this strategy to redirect spending to an under-resourced sector. And specifically, they reallocated dollars from a hospital price growth cap to an increase in the percentage of commercial spending that was going to primary care. What evidence do we have on these strategies? Well, for the price growth cap, there was a peer-reviewed journal article in Health Affairs that showed that Rhode Island's total spending, had a decrease of 8% versus a control group of other states. And so that's significant evidence. But for price caps, we have different types of evidence. This is evaluations done by 2 states that implemented this strategy with their employee health benefit plans. Montana was the first one. They began it in 2016. In the first 2 years, they estimated savings of about $50 million. Again, this is setting a high limit on prices. Oregon did it through legislation. So in Montana, this was a strategy of the state employee health benefit plan, and they went out and negotiated their contracts to a cap. In Oregon, the legislature set the caps also for the public employee benefit program. In both Montana and Oregon, they set the cap at a percentage of what Medicare pays. Okay, there's also been some modeling of federal proposals of doing this that show savings that would result. So if this would be done, it would be necessary to identify which services to target. The cost growth caps and the price caps in the 4 states that I've referenced have focused on hospital services to date, because in those states, it's hospital prices that have been growing the fastest and that have been most variable. But it could be applied at any level. There would have to be a decision of whether this is focused narrowly on a public employee benefit program or as broadly as the full commercial market. There would have to be consideration of how to select the cap. So much as we had conversations within the PPC about how to set the cost growth benchmark, the same thing could be done here with either a price growth cap or a price cap. So in a couple of states, they are using the consumer price index and linking it to that, or CPI plus 1%, which actually turns out this year is very high, but in most years, much more modest. So would be a need to identify an external reference point for determining either a growth cap or a price cap. And then for either, a decision of whether to phase this in over time and also whether to change the value of the price growth cap or the price cap over time. Last, there would need to be a decision of whether to apply how to implement this if it's being done, say, through regulation of price growth cap. So does it apply to an insurer for each contract with a provider, or is it applied across all of their contracts, so they have to net to the cap? And for price caps, is it individual services or in aggregate across all services? Okay, those are other decisions. In summary, we've got some evidence that the price growth caps are highly effective in slowing cost growth. But as I say, this is not for the faint of heart, because of course, this is not going to be popular with providers because it's limiting revenue growth. And the part of the revenue that's been growing fastest and is probably considered most valuable for that reason. So again, I don't want to invite you to make any decisions today, but I want to just invite you to consider the questions of, is this a strategy that Nevada should consider? Why? And is there any additional information that you would want in order to consider this policy option? And I would say number 3 is one of special interest to us today. Do you need anything else? This is not for a recommendation or a vote today, because we have other strategies. As I said, we're going to present both today and during the next meeting. But I see a few of you have your hands up, so let's open up for a conversation.
Sure. Commissioner Van Houweling, please go ahead.
Okay, thank you, Michael. And again, I do appreciate getting the information through the presentations as well. So great discussion and great presentation. Michael, a quick question on a couple of things you had mentioned, which kind of alarmed me from the beginning. The 59% of Nevadans not accessing care. Could you define that a little bit more? Because I know many on this commission and most importantly, the Department of Health and Human Services have done a really good job of reaching out and qualifying Nevadans for the appropriate level of coverage, whether assisted, federally assisted, or state assisted, or emergency Medicaid and other things. So that was my first question that kind of triggered my thought process on where is that coming from? Is that a particular payer in the market? And then if you don't mind, with my other commissioners, I have one other question in the statement.
Sure. So the 59% was one of the findings that Melinda reported earlier on from the CHEST survey. So that's the survey of 1,100 Nevadans. I can only speculate what that is, but we know that at least in the commercial market right now, it's become common to have very large deductibles. So people might have coverage, but when they look at a deductible of $2,000, they might say, I don't want to, I can't incur that expense. So even though I have coverage, I'm not going to access care because of what it would cost me. Okay. I'm speculating a little bit, but that's pretty informed speculation.
Yeah, and you know, from my own experience and many others, we've seen that. I personally saw that during the recession in 2008 here, where people were delaying care, avoiding care because of out of pocket. I mean, and these aren't, you know, I think the word elective gets caught up in the medical terminology, but these are medically necessary procedures. People not getting particular sleep surgeries or delaying care or primary care. I mean, even in 2008, we were seeing delays of mammograms and things that should be routine and covered. And we did see that during the pandemic when the state was closed and people's jobs were kind of on hold or on ice for a while. So certainly agree with that. People do make the determination of paying the mortgage or going to the doctor. So, and then you also commented on the healthcare spending, particularly in hospitals, and certainly living through the pandemic, you know, traveling cost of nurses and PPE and other inflationary pressures, and then student debt for medical students and other things that are provided within expenses. Is that what you're seeing that's driving that period of inflationary costs that are growing so high? And then I do have one statement at the end.
Yeah. So the data that I'm seeing, we're only just beginning to see data from 2020 and 2021. So the trends on hospital prices, especially commercial prices, and this is not Nevada specific data that I'm talking about, because actually that's part of the phase 2 reports that Melinda talked about that we don't have yet. But what I'm seeing in other states is that hospital commercial prices have been, along with pharmacy prices, the biggest driver of commercial spending growth 5 years pre-pandemic. So if you look at, like 2015 to 2020, what was driving commercial spending growth during that time period in most other states, it was prices in those two categories. Okay, and I'm not casting any blame or anything. I'm just saying that that's, just looking at the facts, that's what was causing spending to grow in the commercial market.
Well, good. And I appreciate the conversation on cost growth caps versus price caps. And certainly I'm one that leans more to cost growth controls or discussion versus capping. My rationale is because, as somebody that runs a hospital that has high level acuity services that are some are only first and only Nevada, but we've got great hospitals throughout the state, certainly up in Renown, running some of their unique services there. Sunrise has a great hospital with high level of services that Dr. Khan referred to, such as ECMO, something that we don't do, and they do pediatric hearts. And you've got the Ruvo Clinic here that does great work with neuroscience. So, I get a little worried too when if we put in some price caps. I think everybody would try to operate at a level that's sustainable in the markets versus trying to invest. And I know it. In particular, a lot of people don't see it, but there's a cost for readiness, on-call specialists that are often not recognized by the payers, particularly Medicare. So there's a cost of doing business that typically ends up in uncompensated care or that doesn't get baked into that level of readiness. So, and then also these hospitals that I mentioned do really great work in our communities, serving patients that are diverse and underserved. So we certainly, if we try to level that, we certainly don't want to stop the pursuit of excellence and unique services that Nevada needs that drive people to go to other parts of the country. So just my comments on that. So, as inflation levels off, I think certainly pursuing more of a cost growth versus capping it, again, that will push everybody down to a level that would just be trying to be sustainable versus taking some innovation and growth. So sorry, commissioners, for being so long-winded on that, but I'm going to shut off my mic now.
Thank you, Commissioner. Commissioner McAllister, please go ahead.
Thank you. And thank you, Michael, for this great presentation. I know it's early days, but just based on what Michael presented, I did like the state that set a price cap, but as a percentage of Medicare. And so my rationale is that then the cap itself can grow as Congress changes Medicare rates, and it makes our healthcare system much more of a public good where we're all paying relational prices relational to Medicaid, Medicare, and now commercial gets kind of tied into those two systems. From a patient's perspective, there's so much asymmetric information, right? So the doctor says we need something, and the insurance company says it's a valid thing to pay for or not. We just have to trust it. And from a patient advocacy point of view, having some tie to the Medicare system that is already effective and taking care of seniors 65 and older makes me feel better as a middle-aged person who can't take advantage of that yet. And so going forward, I want to hear more about the state that did that, how it's working, how it's not working, what else we can learn from them.
Thank you, Commissioner. And Commissioner Winkler?
Hello, thank you. This is Commissioner Winkler. So I think for that point 3, it'd be very helpful to see some more in-depth. Specifically, I think Rhode Island might be helpful because I know Mr. Baylett, you've done a lot of work with them. And when we reviewed them before, we talked about how, so just in general, none of these happen in a vacuum. There are comprehensive strategies that are a part of these price caps or price growth caps. And Rhode Island, I know, has a focus on improving primary care as a part of that. And they do have a like a rate review process to make sure that when we're talking about healthcare costs, that includes what it costs to patients, what they're paying out of pocket. So I'd like to see that, what concerns they have, how it's been working. And because I think obviously we're at a very high level here. Thank you.
Yeah. So in response to both of the last two comments, we certainly could arrange for people from these other states to tell you about their direct experience, so you're not hearing it through me. So we could get someone from Rhode Island or get someone from Montana or Oregon to talk about what they've done in their programs, and you could ask them, questions at length.
I think that's a great idea, and possibly understand the stakeholders in that and what they've seen and what's been challenging. Yes, absolutely.
Sure.
Who's next in line, Linda?
Thank you, Chair. Commissioner DeSerbo.
Hey, it's Commissioner DeSerbo. Just a couple of quick comments, I guess, as it relates to point number 3 here in terms of additional information. Some things that come to mind personally, thinking about provider price caps in our state, is that perhaps it's putting the cart before the horse to a certain extent, looking at our number of physicians per capita. And so, looking at these other states, I wonder about the relative prevalence of number of physicians per capita, as well as GME penetration. I know that's something that we've tried to invest in heavily. Certainly Mason can speak to that as well in the state. But looking at GME prevalence, penetration, and investment there in terms of how many physicians are they training and keeping in the state as that relates to number of available physicians. I also think about the credentialing process. I think our state is kind of unique, and I'm curious on these other states in terms of the portability of physicians moving into the market. I'm not a physician, I'm a pharmacist, and I know pharmacist credentialing moving in state is very quick and streamlined by the Board of Pharmacy. In talking to my physician colleagues, it seems like the credentialing process here for physicians is quite lengthy and difficult, and I wonder how that relates to our overall supply and how kind of price caps might affect those just choosing not to enter the market. So that's some other information from these other states that I think might be worth looking at.
Thank you, Commissioner. I did want to notice that there is a chat. And Commissioner Tyler Garner would find it helpful to have information on unintended consequences or latent effects, in addition to strategies employed to mitigate consequences. So just wanted to throw that out there as well.
Is there anybody else?
And then Commissioner Van Houweling, I see you have your hand raised.
Thank you. And kind of back to Commissioner Winkler's comment in regards to, and the earlier question on why people may or may not be accessing care, even though we've done a great job on dramatically reducing the amount of uninsured in the state over the last 10 years. Going back to the discussion on deductibles and copays, and Michael, maybe you can help with this. And I've been doing this for a long time in regards to, and I've seen copays, the deductible goes from $50 to $500 to $5,000, and we keep adding zeros behind them. So is there an avenue for the PPC to look at that? Because I'll tell you, in the medical world, collecting that copay or deductible and margins are extremely thin. We are less than 0.5% at UMC. And so it's a fine line, but often that copay deductible, and I'm not sure who really owns it. We're obligated to collect it per the insurance rules by the payers. But often that's the difference between margin on a case, making money. And sometimes it does come down to $500 to be able to reinvest back into a facility such as UMC. So, I know, and Commissioner Bond's not on the call today, but I think that's something that we do need to look at on how do we shorten that gap so people do make the decision to take care of their health and not delay care or not get their medications. And then they have in the emergency room, which is the most expensive care. So I do think that that's something if we could in this process, look at that. I don't know if we have any authority or some legislative leverage here, but Michael, I'm sure this has come up in other states because it's really shifted it to the patient and they've got to make a decision. So I'll leave it at that, but I would hope we're all affected about it. It doesn't matter where you work or what jobs you have. And sometimes that does break the bank, and people have to decide on getting a life-saving surgery or paying for the house. So just my philosophical comment.
So we're sort of in a vicious cycle. The reason that the deductibles and co-insurance have gotten so high is because healthcare costs have gotten so high. So employers have insurers come to them and say, well, you can have a 15% increase on your premiums this year, or you can double your premium, your deductible from $1,000 to $2,000. And then I'm only going to give you a 6% premium increase. So employers say, well, I don't want a 15% increase. I want a 6% increase. So yes, double my deductible from $1,000 to $2,000, or from $2,000 to $4,000. And so it's a response to healthcare's costs being so high, which then shifts it to the patient. And as we all know, patients are not well positioned to know when they should and should not seek care. And so when they decide based on their pocketbook, they don't seek care when they should many times. So I think, it all comes back to our efforts to try to at least reduce the rate of spending growth. And some would argue that spending is so high right now that we've lost control of being able to give people access to care. But at a minimum, if we can slow it, it won't get worse at the same rate that it is right now. I don't know if that's helpful, but yeah, those big deductibles and co-insurance are a huge problem for access and quality, and for the financial sustainability of provider organizations.
Anyone else before I have something to say?
Sure, Chair Khan, I do have Commissioner Winkler's hand is raised.
Go ahead.
Thank you. This is Commissioner Winkler, and following up on that, so of course, at a minimum, we need to focus on reducing the cost growth. But primarily, my main concern is we do this, that any work we do, it also has to guarantee that that does pass down to patients, that these premiums, these deductibles do go down. And that's really what I'm interested in when we're talking about price growth caps and anything like that, that what are the other steps that we can take to make sure that also happens?
Thank you. Is there anybody else?
Chair Khan, you can go ahead.
So it was just mentioned that when the insurers are providers of healthcare, financial side of it, managed care companies, etc., that they go to the providers for increase, and the providers want increased reimbursement, and so they can either increase the premium or the providers tell them increase your deductible. I disagree with that. And we just heard Commissioner Van Houweling just mentioning that is how difficult it is to get the money from the deductibles from the patient. So I don't believe any providers would tell the insurers, you go increase your deductible, knowing that they won't be able to collect it. The deductible was a big debate, and I happen to be a little part of that during the Affordable Care Act. And it was a big issue. After it was passed, all insurers jacked up their deductibles. And if the deductible was low, the premiums were going to be extremely high. So it became a catch-22, where the insurers jacked up their deductibles of $5,000 to make it look affordable. And at the end of the day, the providers were not able to collect anything from the deductible because the patients didn't have the resources to pay. And that's how the cost shifting took place on the Affordable Care Act. So one has to be careful on the factual history of deductibles and or premiums. So that's all I have to say. Anybody else before we move to the next item?
Any other comments?
If none, we can move to our next item, which is item number 9.
Oh, Chair, we still have a portion of item number 8 to go over.
Yes.
Thank you.
Okay, so I'd like to introduce my colleague, Alyssa, who's going to present on the wide range of prescription drug affordability strategies that states are considering.
Thank you, Michael. Good morning, everybody. Very nice to be with you today. So as Michael mentioned, I'm going to be continuing the discussion of a menu of options that the PPC can consider in terms of potential strategies to pursue for containing cost growth and improving affordability. And within that category, I'm going to be talking about strategies to address affordability for prescription drugs. So the first question is, why focus on pharmaceutical spending? And there are a couple of different reasons to do so. And this is an issue that I recognize also has been the topic of discussion for many meetings here at the PPC. So I'm going to go through some of these reasons quickly. But the first is that pharmaceutical spending growth in Nevada is significant. And we've seen this already through the phase 1 cost driver analyses, both for Nevada Medicaid, which showed that pharmacy spending was among the top 2 categories of spending growth from 2016 to 2019 at 27%, and from the data that we have from the state employee program, which showed that pharmacy spending grew an average of 16% from 2017 to 2020. As noted earlier, there is currently a phase 2 process underway to collect data on pharmaceutical spending, as well as other spending growth from commercial insurers. So we'll have even more information when that analysis is complete. The CHEST survey that Melinda gave an overview of earlier today also shows that Nevada residents have significant concerns about prescription drug costs. Over 55% reported concern, with nearly 1 in 3 respondents reporting hardships over the past 12 months. And a hardship in that survey was defined as somebody skipping medication, cutting a pill in half, or not filling a prescription at all due to cost concerns. And I think it's important to note that while both the level of worry and the reported hardships disproportionately impacted people in lower income households, the level of worry and the hardships were also very high in middle income households. In addition, respondents across party lines expressed a strong desire for policymakers to enact solutions to address prescription drug affordability. And I know you all have not yet seen the full results of the survey, but when you do, you'll note that the support was so strong that over, between sort of 85 to up to 90% of respondents supported some of the solutions that we're going to be talking about, such as establishing a prescription drug affordability board. While modest progress has been made at the federal level to address drug costs, states can take further action to control pharmaceutical spending. And as a reminder for those who may not have been closely following the debate at the federal level on this issue, the bill that was passed and signed into law back in August did include some provisions to lower prescription drug costs for people with Medicare, but did not include provisions that extend to the commercial market. And before moving on, I want to just acknowledge up front that the issue of prescription drug spending is a complex one. And as one of the commissioners stated earlier in the meeting, there are a number of entities in the drug distribution and purchasing channels, from the manufacturer to the wholesaler to pharmacy to patient, and then taking into account the role of PBMs adds another layer of complexity. So because the system is so complicated, there are different approaches that states can take, and there are a number of complementary strategies that can be pursued to address both underlying spending and improve affordability at the state level for medications. So we thought it would be important to acknowledge that Nevada has already made some progress on prescription drug price transparency and passed a number of laws. And so this is a quick overview of those laws, which I'll run through quickly. So first is that DHHS compiles a list of prescription drugs for treating diabetes. It takes from that list as well as other medications and notes those that have had a significant price increase or cost more than a certain amount per course of therapy. All manufacturers of the drugs on that list are required to submit a report with data outlining the drug production costs, profits, and other drug-specific information and pricing data, as well as a report providing a justification for drugs with significant price increases. So that helps understand, again, what is driving price increases. Pharmacy benefit managers, PBMs, must submit reports regarding rebates negotiated with manufacturers for drugs on both the diabetic essential drug list and those drugs that cost more than $40 per course of treatment. And DHS is required to maintain a registry of pharmaceutical sales representatives that market prescription drugs in Nevada. And again, while these laws are all an important first step in understanding drug pricing and what is contributing to price increases, they're likely not sufficient to on their own actually impact pharmaceutical spending and cost. And so that's why we're presenting some other options that can be considered. I also want to acknowledge that there has been interest from other state actors on the issue of pharmaceutical spending. So the Joint Interim Standing Committee on Health and Human Services included 2 BDRs that specifically focus on this topic for the 2023 legislative session. The first builds upon the existing law related to pharmaceutical sales representatives by requiring that these representatives are licensed by the state. And the second BDR would take a number of steps to license and regulate PBMs in the state. It includes provisions that would prohibit PBMs from charging health plans and payers more for a prescription drug than what they reimburse to a pharmacy and then keeping the difference, which is a practice that's known as spread pricing. It would require PBMs to allow their health plan clients full audit rights for compliance. It would establish a fiduciary duty for PBMs, meaning that the PBMs have a legal responsibility to protect the financial interests of their health plan clients, and would prohibit PBMs and certain health plans from reimbursing less for prescription drugs purchased under the 340B program. And again, while these are really important steps in considering how to sort of better understand the role of PBMs and the role that they play in the prescription drug supply and pricing chain, these proposals in and of themselves don't directly reduce spending, and so would be complementary to the types of strategies that we'll be discussing further along in the presentation. So first, we wanted to give an overview of the types of approaches being considered in other states to address prescription drug spending. And I'll just acknowledge that this list here is not it's not an exhaustive list. These are some of the strategies that are being pursued, and even from this list, we're only going to be focusing on a few of them today. So the first 4 here, I'm actually going to skip over because we're going to talk about those in greater detail in the following slides. The next the next category is around using the state's purchasing power to lower prescription drug costs, which would essentially allow small businesses and individuals to buy into a state employee prescription drug benefit purchasing pool. The idea is that by adding more lives to a purchasing pool, purchasers can better negotiate prices for public employees and others who can join the purchasing pool. The next category of policies would promote the use of less expensive drugs. So this includes policies that encourage or require generic substitution to promote the use of generic drugs or over more expensive brand name drugs when generics or therapeutic equivalent drugs are equally effective. Implementing a program called academic detailing, which is an evidence-based prescriber education program, which aims to ensure that prescribers have unbiased information about both new drugs that are coming to market and drugs that have been on the market for a number of years, and the cost and clinical efficacy of those drugs. And lastly, creating a wholesale importation program to purchase lower cost drugs from Canada and make them available to state residents through an existing supply chain. And finally, similar to what has already been passed in Nevada, states have taken steps to enhance transparency around drug pricing to better understand what's driving price increases and also understand how much prescription drug spending is contributing to overall healthcare cost growth in the state. And lastly, a number of states have passed legislation to regulate PBMs, which include a number of the strategies that we just went over that are being considered as part of the BDR process. So the focus for today's discussion, with all of that as context and background, is that we are going to provide an overview of the strategies that states have proposed or enacted to control costs and bring down overall pharmaceutical spending in the commercial market. We'll be looking at strategies that bring down costs and not just strategies that focus on purely consumer affordability, such as capping out-of-pocket costs And to some of the discussion that happened earlier, we can also talk about how some of these strategies can both address underlying costs as well as have the goal of addressing affordability. And for the purpose of today, we will not be discussing strategies for Medicaid and state employee health plans, but those programs do have additional levers to address prescription drug costs within their programs as purchasers. Many of the efforts that we'll be going over today are recent, so experience in states that are either pursuing them or have passed legislation is new and early in implementation. So some of the sort of lessons learned will be limited to date. So in the realm of looking at prescription drug prices and affordability, one may ask, why can't we just set prices for prescription drugs? Why can't we directly regulate the price that a pharmaceutical company can charge for medications? And the reason we can't do that is because pure price setting would violate federal law. So first, there are federal preemption issues related to patent law, which means that any state that seeks to limit industry profits would be allegedly violating federal patent rights, which triggers the Constitution's supremacy clause, which claims that federal law is supreme and will always supersede state law. And the second reason is because of the Dormant Commerce Clause, which prohibits states from passing laws that discriminate against out-of-state commerce, unduly burden interstate commerce, or regulate commerce occurring outside the state. I'm happy to pause and take a question. Sure.
I'm so glad you brought this up because I've always wondered, I understand the federal laws that stop price caps, but there are also laws that stop price gouging, that for profit, you can't charge excessive fees when a consumer only has certain limited options. And I'm wondering why those don't come into play with something like a prescription drug.
The question is why those laws wouldn't, can you clarify the question?
Sure. So like during a hurricane, when they try to charge too much for bottled water, there is a limit to how much profit you can make when an American consumer only has certain options. And I've always wondered, in light of, I understand the federal laws that you can't infringe on the patents and the ability to make money. And yet there are consumer protection laws that also protect me as the patient from getting gouged by an entity that I have no other alternative product that I could buy.
Right.
So I'm wondering why that, I never hear those brought up in the context of the discussion you're raising now.
As a sort of reason to potentially look at costs that consumers are paying under.
Exactly.
Yeah, it's a good question. I know that in Maryland did propose previously a price gouging law, and I'm happy to dig up some of the research on that. It was deemed, it was essentially not upheld in the courts. And so we can certainly go back and take a look at that research and come back to you with sort of the legal reasons why that law wasn't upheld.
Oh, I appreciate that. Thank you.
Sure. Okay, so moving on to then how to address prices and costs without actually setting prices. So two proposed approaches to do this are, first, that policies can regulate payments, meaning what a particular purchaser pays for a prescription drug, as opposed to regulating the price. The pro of this approach is that it has a very direct and immediate impact on reducing spending. A con is that a state can only regulate what a fully insured health plan pays, but cannot regulate payments in the self-insured market due to federal ERISA preemption. However, if this type of policy were to be pursued, a state could also create an opt-in option for self-funded plans so that those plans could benefit from savings captured by paying lower rates, because it would in effect benefit the plan itself. A second strategy, and I'll just say that for both of these sort of types of strategies, we'll be giving specific examples of policies that use these types of strategies. So the second strategy is to tax excess prices or excess price increases. The pro is that this would apply to all sales in the state and not just those paid for by fully insured health plans. A con is that it may not directly reduce spending, meaning that a pharmaceutical company could be incentivized to keep prices or price increases below that threshold in order to avoid being taxed or being penalized. However, they could also opt to just pay the tax. And then there would also be the question of funds that are collected from that type of tax. How would they be used? Could they be used to actually impact spending, or could they be used to address consumer affordability? But even so, the impact on spend would be indirect. Okay, so now we're going to focus on 4 strategies here, again, to provide an overview of those that have been proposed in other states to control prices. And the first you all are very familiar with, establishing an upper payment limit. So I'm not going to spend much time here. And as you all know, this would typically happen first by creating a PDAB, Prescription Drug Affordability Board. And there, one sort of set of considerations that a state, including Nevada, would potentially want to take into account when, if this is an option that wants to be further pursued, is sort of the level of detail that's included in a legislative proposal versus what happens at a regulatory or implementation phase of something like this. So thinking about what type of information is used in conducting an affordability review and essentially determining if a upper payment limit would be warranted for a particular drug. I want to acknowledge that there was some public testimony submitted on one of the methodologies that has been proposed in other states, the quality adjusted life year, and how that methodology values the lives of people with disabilities. And this is a really, it's a complicated issue. And I would just say that if it's something that the commission would like to pursue further, we're happy to pull together some resources and sort of discuss that with you all, send out materials in advance and discuss that with you all as a group, because this type of proposal, setting an upper payment limit, can happen either with utilizing a metric like the quality or using other metrics. And so probably a topic worth pursuing if you all want to get into that level of detail. So next here is another strategy that would essentially establish upper payment limits, but through a different process. And that process would be through international reference pricing. So that is based on the widespread recognition that drug costs in other countries are often much lower than in the US. And so instead of importing the actual drugs, we could think about importing the prices of those drugs. So the policy would first entail identifying which drugs would be subject to the reference rate, likely determined by the drugs that are most costly to the state, taking into account both net price and utilization. Then a state would be authorized to establish the international reference rate for that set of drugs based on prices in another country or countries, which then in effect becomes the state's upper payment limit for a drug, meaning that payments in excess of that reference rate would be prohibited. In model legislation established by NASHP, which is the National Academy for State Health Policy, they proposed establishing a reference price based on the lowest price in the most populous provinces in Canada, in large part because the Canadian system for establishing a maximum price ceiling already takes into account prices from a number of other countries. So instead of doing the work to examine the prices from those countries, one could use Canada as the reference price, as it would be less time and resource intensive. Some benefits to this type of policy are that cost savings would be significant, and at the same time, administrative expenses would be kept low by building on a state's existing infrastructure, and could be, I'll just say, lower in terms of state resources than something like establishing a prescription drug affordability review board, which could entail sort of a whole new entity at the state level. The second set of strategies are those that would tax excess price increases or prices. And so the first here is a prohibition of unsupported price increases. This strategy would impose a financial penalty on pharmaceutical manufacturers whose drug price whose drug price increases, are unsupported by new clinical evidence, as determined by an entity called ICER, which stands for the Institute for Clinical and Economic Review. ICER is an independent research organization that serves as a watchdog on drug pricing. Each year, starting in 2017, ICER conducts an analysis by starting with identifying and evaluating high-cost drugs, up to 13 in total, so not a huge list, and determines whether or not a price increase is supported by new clinical evidence on safety and efficacy. They then issue a public report with their findings. And just to give you a sense of the number of drugs we're talking about here, in the most recently available report, they examined 10 drugs in total and found that 7 of those 10 drugs lacked adequate new evidence to demonstrate a substantial clinical benefit that was not yet previously known. For the drugs where there is an unsupported price increase identified, a fine would then be assessed. The model that we're looking at would be 80% of the difference between the previous list price adjusted for inflation and the current list price. And then again, the questions that I raised before of if there is that type of assessment that takes place, that type of penalty, the state could determine sort of how to direct that spending, whether it goes to a fund to improve affordability or whether it goes to a general revenue fund or some other state initiative where additional funding is needed. And again, under this model, a manufacturer could be encouraged to avoid an unsupported price increase in order to avoid paying a penalty, but that would have to be, this has not yet been implemented anywhere, so we don't know yet how that would play out. Some additional benefits of the policy are that it impacts the most frequently prescribed high-cost drugs. The number of drugs, as I mentioned before, are limited, and it minimizes a state's administrative burden by using existing data sources. And the final strategy here is that one which would penalize excess price increases. So this uses a similar mechanism to taxing excess price increases that I just discussed, but in this case, a financial penalty would be imposed on a price growth increase that is faster than a target rate, which would typically be set at inflation plus a specific amount. So in the 2 states where this has been proposed, Massachusetts and Connecticut, the target was set at limiting annual increases in drug prices to no more than inflation plus 2%. And in those proposals, a per unit penalty would be assessed on all drugs dispensed or administered that have an excessive price increase above that threshold, calculated as 80% of the excessive price increase. Okay, so that is where we are here with in terms of an overview of the cost growth strategies that we'll be discussing for prescription drugs today. So then we wanted to raise to the group a similar set of questions as we talked about before for the price growth cap policies. So first is, are these types of policies ones that Nevada should consider pursuing in terms of addressing prescription drug affordability? We made the assumption that these would be in addition to or complementing the Prescription Drug Affordability Board, as the PPC has already shown interest in that policy. Is there any additional information that would be needed or that you would like to have in front of you for that discussion moving forward? And that could be related to the materials and content that I just presented, or other strategies that you would all like to discuss. And again, we are not here asking for any kind of formal vote on these particular strategies, but more just wanted to present them as a menu of options and to see if there's any further information that would be useful moving forward.
Thanks, Alyssa. I just want to recognize Commissioner Winkler. You had your hand raised.
Yes. So sorry, this is Commissioner Winkler. I definitely want to get a lot more information about referencing and specifically international. Well, that's the only one that would work. And my reason for that being that if there is the work already done to find, especially if we're looking at Canada, seems like a much less administrative burden to quickly see that and do that. I think For anything also that we are going to review, it would be helpful to identify, so since it's pharmaceuticals, what pharmaceutical legal challenges will be tried and what have they had tried previously? How does the Dormant Commerce Clause come into play there, especially if we're looking at rate setting regulations, if we're tying it to international reimbursements. So that topic is very, very interesting to me, and I think would be very good to review with the board.
Thank you.
Anybody have a comment?
Yes, Commissioner McAllister, please go ahead.
Thank you. So I think Nevada and our patient protection commission's really fortunate that other states are doing all of these so that we can watch and see what happens there. I too am really excited to learn more about international reference pricing. I think that's a great concept, the idea that the cost of implementing it is low and the impact potentially could be very high. That is something I'm very excited about. The plans that put penalties in place, I fear that those may be less effective, and I'll be curious to see how it works out in those other states, because I think it just becomes the cost of doing business. So, right, so they're going to raise the prices of the drugs anyway and just account for the penalty fee that they might have to pay on top of that. So those I'm less excited about.
Thank you, Commissioner. Commissioner DeSorbo?
Hey, thank you for that presentation. I guess just a couple thoughts, maybe in kind of two areas. You know, whenever I see kind of penalties for excess prices or unsupported price increases, I always get a little bit concerned. Someone made the comment earlier about prescription drugs are not in a silo, but sometimes we treat them as if they are. And I think that could be potentially problematic. I know we're not talking about the Medicaid population today per se, but just to give some examples, currently Medicaid for service, we are prohibited by statute to cover anti-obesity medications. And it's something that we're looking into potentially adding in the future, where we would have an increase in spend, where we would be spending more on certain medications, but at the offset of improved health outcomes, where you help individuals lose weight, their diabetes gets better, their hypertension gets under control. You have downstream effects in a different silo. And by just kind of looking at prices, sometimes you miss out on the very important offsets. I think about other things, again, just illustrative examples from the Medicaid point of view is diabetes medications, right? We often spend more on our preferred drug list for our fee-for-service population on a medication that has better outcomes. And again, that patients do better, less risk of amputation, less risk of going blind. Again, cost offsets other than the prescription drugs that accrue in a different silo. We do it on the inpatient side as well too, right? We often spend a lot of money on very expensive antibiotics that are far more expensive than other options, but these get the patients out of the hospital faster, prevent bounce back, prevent it getting dinged by the government in terms of CMS clawbacks and so on. And so I always kind of worry about, like, you know, penalization for prices when we look at drugs in a silo. I guess my second kind of set of comments, I really appreciate the slides looking at PBM reform in this state. Certainly, if any of you are familiar, right, there was recently a very landmark Supreme Court case looking at PBM regulation. And I know we have something that appears to be going forward in our next legislative session, and I can't overstate that enough. It looks like SB 392 will be reintroduced, if it hasn't already been, for consideration in 23, and that looks at PBM reform. And we went over that as one strategy, and it almost seems like an afterthought, but I really think that this board should look at supporting that in a lot of different ways. I think that will do wonders for prescription drug affordability. It's not a perfect bill. There are some things we can add to it, which we can certainly talk about potentially at a future date in terms of some PBM practices in the state that are harming patient access, that are increasing prescription drug prices and harming patients. And it's something that needs to be looked at. So I guess those are two of my general comments overall. Thank you.
Thank you. Anybody else in line?
Yes, Chair. I do see in the chat feature, Commissioner Tyler Garner noted, given the role prescription costs are playing as a driver, I think we should consider affordability strategies. And then also in support of our efforts, it might be helpful to know if there are other comparators and any limitations to using Canada as a comparator.
Go ahead, who's next?
Are there any additional comments?
If you see none, we can move to the next agenda item.
Seeing none, Chair.
Thank you. So our next agenda item is on the, let's see, it's public comment. Anybody there for public comment?
Thank you, Chair. As a reminder, if you're using the Zoom platform, please raise your hand. And if you are on a telephone, please press *9 to raise your hand. Are there any public comment? Seeing none, Chair.
Thank you. So basically, no public comment. There's no other comment from anybody else, so we can adjourn. I think we stand adjourned. Thank you very much.
Oh, I'm sorry, Chair Khan. I know we're almost there and in record time too. So just as we're closing it, maybe under emerging issues, I would like to see if we could talk perhaps on our future agendas. And Chair DeSerbo or Commissioner DeSerbo mentioned this earlier on the lack of GME slots and the growth of medical professionals in the state. And just for comparison, the state of Nevada has 407 CMS approved slots. That was set back in 1996. And as the East Coast moved to the West Coast, a lot of those slots never moved over. So I think that's something that we could, back to kind of my original comments when we had our first couple of meetings, of looking at specialties to where we can grow together as a state and help the governor and others try to grow those GME programs, which I know he's keenly aware of. But maybe just in the future meetings, I'd like to be able to extend an invitation to the dean of both medical schools, UNR and UNLV, to just come and give us their global thoughts on healthcare and where we should grow. And then just my last request, I reflect back on our first meeting that was in person at the Grant Sawyer building, and I was just curious if there's an opportunity for us to get back in person. I'd be willing to go north, south, and fly wherever I need to do for this meeting. But if there's any chance, I just miss the dynamics of working together side by side, shoulder to shoulder, but also interacting with the public and the staff. So I just would like to go on the record if we can get together, and I think that builds camaraderie and cohesion with the team. So just my thoughts. Thank you, everyone. Enjoy working with you.
I endorse your thoughts, and I think, Melinda, you can look into this agenda item regarding GME. It's a very important item, as Commissioner Van Holling mentioned. And then regarding in-person meeting, Melinda, could you kindly do some homework about the logistics to see if we can get it started, and let us know what you find out through an email.
Yes, absolutely, Chair. Thank you.
Thank you so much. So that's called for adjournment now. We stand adjourned. Thank you, everybody.